Hi everyone, this is Dr. Stephen Rankin. This presentation examines muscular imbalances, compensations, related pathologies, and exercise as a medicine-based approach to postural correction using real case observation. I'll connect some of the most important principles from the Medical Exercise Specialist Manual and current research on core stability, myofascial integration, and movement function. In addition to the class text, I also employed several resources which are mostly derived from the table of contents of that text. I also employed pictures that are stock photos. Every single one is derived from Microsoft, and wanted to cite that as a credible reference, as it's basically a royalty-free option. This is a case review. My subject is my wife, whose photo was not used in this at her preference. The photos used do represent specific activities that are related to the subject matter, just simply to make this topic more interesting. I wanted to examine how fascial slings and core systems integrate for the restoration of efficient movement and posture. This model does blend structural anatomy with functional lifting and training concepts drawn from McGill and Myers, which are in the references. Thoracic kyphosis, scapular protraction with a head forward tilt, anterior pelvic tilt, slight in-toeing, complaints of hand pain, which may represent carpal tunnel or possibly even cubital tunnel syndrome, were postural observations, and these imbalances are consistent with upper and lower cross syndromes, which affects both balance and neural function, as well as tensions across the spiral of fascia. It's important to understand the core function in balance and gait. The core does stabilize the spine for distal efficiency, allowing a solid basis for using the extremities. Co-contraction of the specific muscles, including the pelvic floor, the core, the multifidus diaphragm, help stabilize for effective movement. The oblique and spiral slings link the shoulders and the hip for gait control. And once again, it's important to understand that this works in a concerted effort across both posterior and anterior chains. The core does serve as an anchor, while the extremities adapt dynamically to maintain the equilibrium, which is why we're designed to walk by swinging our arms and moving in a pattern that's effective. In addition to the postural observations and the dynamic observations, balance and recovery strategies are important. An assessment of thoracic kyphosis, scapular protraction, forward head posture is not atypical. However, they can create some anterior grade leaning and increase the risk of falling, especially in sports. It's important to invest in incorporating other strategies such as ankle strategies for small sway control, use of hip strategies, larger body corrections, increasing awareness of this, step strategies to reestablish the base of support. And it's important to explain this to the client in such a way that they understand that balance starts at the ankles, moves up the hips, and involves a step if sway exceeds limits, so performance and health and safety can all be involved. Balance recovery does occur through a progression of many strategies, including the ankle strategy, moving upwards, and it's important to understand that a static to dynamic balance progression is also important. We begin with static because it's a gradual progression to more dynamic control. The stance sequence moves with the bipedal to semi-tandem, tandem, or a single leg. Sometimes there can be alterations in this with sensory challenges added, and some of these can be sport specific if the client were interested in certain sports. In this case, the client's more interested in just improving posture and working on a distance run. The challenges such as foam pads and eyes closed, many other recommendations to make it more multi-directional, can help build proprioception and agility. core and myofascial sling exercises. This incorporates content regarding the selection of exercises as required by the assignment for 16.4, the table in 16.4. The stabilization, diaphragmatic breathing, abdominal bracing is an important concept. Anterior oblique activity, plank, cable press, high to low chop, and some of this may need to be modified a little bit. Holding plank does strengthen the posterior chain and the pecs, which may help pull the shoulders forward more in a protracted position, so there may be better alternatives, or this might be minimized. Posterior obliques, holding bird dog, single arm cable pull, deadlifts. There are other exercises including lateral side plank, lateral lunge, which also engage the obliques and the core. Deep longitudinal bridge, RDL, Turkish get up. These are all really functional activities and are useful in clinic for patients as well as clients, as they do help with fall recovery and prevention of falls. Exercise does tend to progress, once again, in a way that's stable to more mobile, integrating the fascial lines with core endurance. And it's important to understand that training endurance before power may enhance motor pattern control and reduce injury risk. In this case, it's somewhat up to the individual. For general health, there may be other concerns more than simply addressing the front and lower cross syndromes. Now I want to talk about the clinical integration related to kyphosis and neural tension. The last slide depicted kettlebells, which were used for basically a goblet squat. It's one of my favorite modalities for addressing these. I like the use of lighter ones to challenge more dynamic patterns, as well as focusing on protraction with rows and alternating back and forth, because it tends to create a balance when you kind of superset those. So that might be my own twist on this approach. Kyphosis is often related to tight pecs because it does pull the scapula forward. It can lead to neck flexor weakness, where the head's held forward, and office work can exacerbate this, which is relevant in this case. Possible neural restriction along the deep front arm line can be a problem. Adding chin tuck, retraction, wall slides, median nerve glides, possibly maybe an ulnar nerve glide if cubital tunnel is suspected, because there is a complaint in this client of pain in the hands. But once again, per our arena, our domain of practice, we don't want to treat unwell folks. This might be a good opportunity to refer back to a therapist. Addressing thoracic posture can reduce the distal compression and reduce hand pain in carpal tunnel as well as cubital tunnel. We have to be careful with these exercises because exercises such as plank can exacerbate them. To conclude, there's a lot to cover. However, in general, the core stability does drive postural control. Myofascial integration is important because it ensures balance, load transfer across the body, and it as well is affected by repeated load transfer across the body. Prioritization of endurance, mobility, and pattern retraining before strength and power, we can prevent compensation and improve functional movement effectiveness. This is an integrative model which demonstrates how exercise medicine, and it is indeed a very powerful medicine, can restore harmony between structure and function. With regard to this specific client, I'm aware of her activity, and activities such as kettlebell use, dynamic activities with possibly a greater focus on the posterior chain to minimize the forward cross risk associated with increasing the pecs too much. The exercise illustrated in the pictures here, the front squat tends to have greater transfer to many sports, in my opinion, and the use of a kneeling posture can eliminate compensation at the ankles and hips and allow greater understanding and possibly even further assessment in a very functional way. So the second picture does have pertinence to this issue. This does demonstrate the interaction of static and dynamic components of balance integrating with the fascial sling activation, and it is important to understand that this must be highly tailored. And with regard to this client, there are many instances in which a therapist or physician approval must be attained because we're once again outside of our arena when we're working with unwell patients, people who are over a certain age and have had diagnoses that can cause complications. There are also a number of references that were derived specifically from the text to reinforce the ideas that we were examining, and I wanted to point those out as well. I wanted to cite several references and make a recommendation. I used the text and several references from the bibliography of the chapters that we looked at. In addition, I referred to several videos of Stuart McGill's, and his take on some of the concepts are different. In fact, I would probably go with a few different exercises based on his work, which somewhat may counter some of the ideas of the text. I included a video by BackFit Pro at the bottom of this list, simply as one that's recommended because it would help formulate my opinion on what we should do as far as approaching this issue and how to understand it. All right, appreciate your time and your consideration, and have a great day.